day ahead of transplant errand.
Dr. Besha,
Yes, Dr. Khadar.
can we start?
Yes, just 1 minute to have all the participants, and then I will start. I think it's time to start. So, dear colleagues, ladies and gentlemen, on behalf of the AFRAN Transplant Committee, it's my great pleasure to welcome you all to today's webinar entitled Overcoming the Organ Shortage Challenge. This webinar is part of our ongoing AFRAN Transplant webinar series organized every 2 months. I'm really very proud to note that this is already the sixth in the series, reflecting our committee's continued commitment to education, dialogue, and advancement in transplantation across Africa and beyond. I would like to sincerely thank Dr. Mariam Khadar and Dr. Gamal Saadi, coordinator of our webinars subcommittee, for their tremendous efforts in organizing today's event. We are deeply honored to host outstanding speakers and moderators, renewed experts in the field of kidney transplantation. Dr. Lionel Rostin from France, who will present on ABO compatible kidney transplantation, and Dr. Zunaid Bardey from South Africa, who will present on kidney pair donation. Our session will be moderated by an exceptional panel, Dr. Ahmed Halawa from the UK, Dr. May Hasaballah from Egypt, and Dr. Michael Rees from the USA. We are truly grateful to all of them for accepting our invitation and sharing their valuable expertise. I would also like to warmly thank all the participants who have joined us today. Please note that the discussion session will take place after both presentations. You are most welcome to post your questions in the chat throughout the session, and our moderators will address them during the discussion. Without further delay, I now hand over to Dr. Khadar and Dr. Saadi, who will introduce our distinguished moderators. Thank you.
Thank you, Dr. Besha. So, the organizing committee is delighted to have hosted this sixth webinar on overcoming the organ shortage challenge, and we are pleased to welcome Professor May Hazaballah as moderator. She is professor of general medicine and nephrology in Cairo University. She is immediate past president of the Egyptian Society of Nephrology and Transplantation and head of its registration chapter. She is treasurer of the African Society of Organ Transplantation, the AZOT, and she's a North Africa representative of the Middle East Society of Transplantation. And we have with us also Professor Michael Rees, who is a distinguished professor of urology and the surgical director of renal transplantation at the University of Toledo Medical Center. He also serves as the CEO of the Alliance for Paired Kidney Donation and Rejuvenate Healthcare. Together with his father, he created the first internet-based kidney exchange software system in 2000. In 2006, he formed the Alliance for Paired Kidney Donation, which provides kidney exchange service to approximately 50 participating transplant centers across the United States and 15 countries around the world. So we can we can start.
Dr. Rees, please.
Thank you so much for that introduction. And hello, everybody. We're very excited to present today's presentations on how to meet people whose donors don't match them because of ABO incompatibility or antibodies, and the solutions we're going to hear about from Professor Rosteng, who joins us today from, I'm guessing, from France. He's a distinguished French nephrologist and professor. He's internationally recognized for his groundbreaking work in kidney transplantation with a special focus on desensitization protocols for ABO and HLA incompatible living donor kidney transplants. He's also known for his clinical research, which is viral infections in dialysis and post-transplant patients. He's published more than 440 peer-reviewed articles. He's actively involved in a number of different professional societies, and we're fortunate today to have Dr. Rosteng speak to us because his interdisciplinary research spans nephrology, immunology, internal medicine. His work's been cited thousands of times, and I'm really looking forward to his presentation. Professor Rosteng?
Okay. So thank you, Michael, for the introduction. Thank you, Professor Mohammed, and all the co-chairs who are hosting this wonderful webinar. So my task is to address ABO incompatible kidney transplantation with regards to having a success indeed, and my contender will address per exchange program. Okay, so I have nothing to disclose with regards to this presentation. So when we talk about ABO incompatible kidney transplantation, we are dealing with combinations who are in red. That is to say, the donor is AB or A or B, and the recipient is O, or the recipient is A or B and received a kidney for A or B, vice versa, or AB. And indeed, we have antibodies, isoagglutinins, that are directed against the blood groups that we do not have. And these isoagglutinins are either IgMs or IgGs and might concur to having acute humoral rejection. And indeed, the immunological barriers we're facing with in the setting of ABO incompatible transplantations are the isoagglutinins, as I said. The IgNs are why is that? Because when they are present around at the time of transplantation, they might result in immediate rejection or thrombotic microangiopathy, which is an event that occurs between day 1 and day 5 post-transplant. Conversely, if IgGs are still present at the time of transplantation or within the next days, this will result in delayed acute antibody-mediated rejection, which is much more easier to treat as compared to traumatic microangiopathy. And by the way, the titers of IgGs are always greater than those of IgM. And therefore, if we want to have a successful ABO incompatible kidney transplantation, we have to desensitize the patients pre-transplant. That is to say, we have to remove the isoagglutinins that might result in rejection. So, what is the rationale for having ABO incompatible kidney transplantation? Indeed, in countries where only living kidney transplantation is possible and where SWAP programs are not yet implemented, the only solution, if we want to expand the donor pool, take on board ABO incompatible kidney transplantation. And so just to refresh our memories with regards to the history of ABO incompatible kidney transplantation, it started in 1981. At the same time, both in the US and in Europe, in Brussels, in Belgium, and these were two cases of inadvertently ABO incompatible kidney transplantation. That is to say, there was a mistake with regards to the donor blood type, and by chance, the recipient had very low levels of vitamins, and therefore the patients were not lose their graft immediately. And when I was a medical student, I remember in 1987, we have had a patient who inadvertently received a deceased donor ABO incompatible transplant, and she lost her kidney graft by day 4 post-transplant. So from 1982 onwards, for a few years, the Brussels team led by Professor Alexandre protocolized ABO incompatible kidney transplantation in a way that pre-transplant the patients were submitted to desensitization, where in those days was relying on splenectomy because spleen is a big reservoir of B cells, plasmapheresis to remove the isoglutinides, and immunoadsorption. And in those days, immunoadsorption was started pre-transplant and it was based on steroids and azathioprine. The problem was not hyperacute rejection, because the patients, even though they retain some titers of isoglutinin post-transplant, they had a good renal function, and this was termed accommodation, which is not tolerance, because tolerance is a setting in which the kidney transplant is functioning well without any immunosuppressive drugs, whereas here we need to have immunosuppressive therapy in order to maintain a good well function. This is accommodation. This is an active process. However, the program was stopped because there were a huge number of patients having infectious morbidity or mortalities. And indeed, death of ABO incompatible kidney transplantation occurred in the 1990s in Japan. Why? Because in Japan, the Shintoism prevent the people from donating after their death, because the concept of brain death is not accepted. And so therefore, for liver and kidney transplantation, they only rely on living donors. And so therefore, to expand the donor pool, they developed ABO incompatible transplantation. Why is that? Because tacrolimus, which is a very powerful calcineurin inhibitor, became available in 1994. And splenectomy was still in order to remove the B cells until 20,000. And at this point, in 2000, splenectomy was replaced by rituximab, which was able to remove the B cell pool. And indeed, this combination of tacrolimus plus rituximab resulted in very good results. And so this is courtesy slides from my friend, Professor Ekawa, which runs the Japanese ABOI registry, whereby you see with a time frame of more than 20 years, the patient survival is excellent, 73% at 20 years, and the graft survival is 52% at 20 years. And when they look at in the registry those patients who have had splenectomy, the red ones, and those who have had rituximab, converse, those who have had splenectomy, the blue curve, and those who have had rituximab, you see there's a huge difference with regards to graft survival, i.e. The graft is far much better for those who have had rituximab. And this benefit in terms of graft survival occurs within the first weeks and months post-transplant. That is to say, rituximab the isoglutinin rebound and therefore avoids the antibody-mediated rejection. So a few words about isoagglutinins. So as I said, it's natural antibodies, IgMs or IgGs, and there are three ways to assess them. The test tube, which is very easy. We're going to go through it in the later. The gel card, which is used in routine, and it's able to separate out the IgGs and the IgMs, and the flow cytometry, which is only an experimental test because indeed it takes too much time. And so, for example, we take the serum on right hand or left hand side, and we take erythrocytes, A or B erythrocytes. And so we observe hemolysis, and so therefore we dilute the serum 1:2, and we perform the test, see hemolysis, and then we dilute 1:4, and at this point we say that there is no hemolysis. So therefore we say that in that patient, the isoglutinin titer is 1:4, and the lower the titer, the better the outcome, and the less desensitization is required. So recently there was a paper from China that assessed 210 samples of ABO incompatible candidates, and there are three methods: the test tube, which is the most the easiest one, the gel card test and the glass bead card test, GBT. And they wanted to know whether the results were comparable or not. And so, first of all, they look at the non-O blood group, that is to say, the A and the B patients. As you can see in blue and red, the results are very similar. Upper panels IgMs, lower panel IgGs. You see there is almost no difference with regards to the titers with test tube and gel. Conversely, for the GBT test, the values are always higher, both for IgMs and IgGs. And so the message from that paper is very important. It's that for one given lab, when you have to stick to one method, you are used to it, and the results are reproducible. And so you don't have to skip to change from one method to the other. You have to stick to one method. And this was for the patients who were of blood group O. We know that patients who are blood group O had significantly higher levels of isoglycines, anti-A and anti-B as compared to those who are group A or B. And they found the same result, that is to say, the GBT test shows always higher values. So this was a paper recently published from India, whereby they assessed almost 1,800 kidney transplant candidates for ABO incompatible transplantation, and they look at the isoglycine titers before desensitization. And what they found was that the cutoff value being 1 into 8, only 13% of the candidates had very low isoglycine titers to start with, whereas the others had very high titers, and some of them having titers greater than 1 in 1,000. And at the end of the day, they were transplanted. So, in order to safely perform an ABO incompatible transplant, we have to get rid of IgMs, because IgMs, when they are still around, they result in acute rejection on the table or delayed as a matter of thrombotic microangiopathy. And the cutoff titer for IgMs is 1 into 4. With regards to IgG, it's 1 into 8. And we have to focus also on peri-transplant transfusions. Should the patient need red blood cell transfusion immediately pre-transplant or at the time of transplant or the next days, the red blood cells have to be of the same group of the recipient. Conversely, this is different from the plasma. Indeed, the patient has been desensitized, and therefore we have to be very cautious. And so if it's B or A into O, the plasma should be group of the donor. Conversely, if it's B or A, if it's B into A or A into B, the plasma should be AB. And you know, plasma AB is very rare. So how can we get rid of the undesired antibodies, that is to say, the isoglycinins, where we have two ways to get rid of them, apheresis and immunosuppression at the same time. So with regards to apheresis, we've got three tools, sorry. Plasmapheresis, the standard one, which is not expensive, which depletes to some extent clotting factors. But the problem is that we only can treat about 4 liters of plasma per session, and the replacement fluid can be either fresh frozen plasma. In many countries, it's very cheap, or albumin in Europe, where albumin is far much cheaper than fresh frozen plasma. We can move on to double filtration plasmapheresis, DFPP, which is more efficient than plasmapheresis at removing the isoglycines, because we are able to treat far much more plasma volumes. However, it depletes clotting factors such as fibrinogen and factor 13. However, for DFPP, we do not have replacement fluids. And finally, when the titers are very, very, very high, we have specific immunoabsorption, IA. That is to say, we're using columns who are trapping either the anti-A or the anti-B antibodies. And these columns are normally marketed for single use, but we can reuse them. Not in France, it's forbidden, but in some countries they are reusable. And indeed, we developed and we published the paper in 2016. We can have long-lasting sessions of specific immunoadsorption, which last 8 to 10 hours. And in the meantime, we're able to process 15 to 20 liters of plasma. And so therefore, as you know, the IgMs are only within the vessels. Conversely, the IgGs are both interstitial and in the vascular compartment. And so therefore, there is a refilling from the interstitium to the endovascular compartment during the long-lasting session. And therefore, it limits the rebound post-apheresis. And so we know that one session of specific immunoadsorption is able to reduce the titer by 4 dilution, which is quite big, whereas the two other techniques, DFPP and plasmapheresis, reduced by 1 or 2 dilutions. And the whether the rebound is limited with specific immunoadsorption, whereas it's quite big with DFPP and plasmapheresis. So indeed, it's important to remove the isotretinoin. So it's very important to prevent their resynthesis. And so this is achieved by using rituximab, which is always needed. So the question is when and which dose? Well, roughly the earlier the better. And so most of the teams are infusing rituximab by day minus 30 pre-transplant, and indeed it replaced splenectomy. And the dosing is between 100 to 500 milligrams. In Asian countries, they tend to use 100 to 200 milligrams, whereas in Western countries, we are most likely to use 500 milligrams, a single dose. And at the same time, we start anti-infectious prophylaxis. It's very important to prevent meningococcal and pneumococcal infections. And for that, we use phenoxymethylpenicillin, and to prevent pneumocystis reactivation by using cotrimoxazole. And 2 weeks before transplant, we add a standard immunosuppression by using tacrolimus, which will inhibit the T cell. And indeed, the T cell help is important to activate the B cell, so we have to block them, plus mycophenolate mofetil that targets the B cell, plus steroids. And so this is the case of a male patient, a young patient, who was age 33, unknown GN. He was on hemodialysis for 1 year and a half. And he had an unrelated kidney transplant donor. It's possible, it's legal in France. He was transplanted in May 23, and it was A into O. And to start, the titers of isoclin was very high, more than 1 in 600. And so you see, we started with the FPP, but after 3 sessions, the titers were still very high, more than 200. And at this point, we perform a specific immunoadsorption session, Glycorex. And so it brought down the titers, both IgM in red and IgG in blue. But after a few days, there was a rebound. And so we kept on with DFPP, a few sessions. And the day before transplant, as we do for every ABOI case, we perform a plasma exchange, whereby plasma is replaced by fresh frozen plasma in order to replenish the clotting factors that have been removed the day before by DFPP. It's very important to replenish the clotting factors in order to avoid bleeding during surgery. So the question that arises is to know whether rituximab is really necessary, because indeed rituximab, by depleting the B cells, might be associated with more infectious complications and with more hypogammaglobulinemia in the long run in roughly 5% of patients. So this is a case series from Australia, 2 periods. The first period, all the patients were desensitized with rituximab. Second period, they skipped rituximab. They were just performing apheresis if needed, and they compared the results to a series of patients who were ABO incompatible, living kidney transplanted. And what they found, that the rituximab-free ABOI patient, as compared to the rituximab-treated ABOI patient, had a significantly increased risk of acute rejection. You see, it was 8 times more, which is huge. And in addition to that, all the kidneys were lost were in the ABOI treated patients without rituximab. as well as the refractory ABMRs that required splenectomy in order to save the kidneys. They were only observed in those patients who have had no rituximab. So at the end of the day, this study clearly demonstrates that we need to have on board rituximab for the desensitization process. Another study recently published from Japan, it's not randomized. However, they focused on the patients who have had titers to start with into 32. I recall you that the target is 1 into 4 for IgMs and 1 into 8 for IgGs. And so the cohort has had no rituximab, whereas the most recent cohort has had rituximab therapy in addition to apheresis if needed. As you can see here, with regards to the acute survival, the patients who have had rituximab did never present acute rejection. Conversely, those who have had rituximab did not have rituximab presented antibody-mediated rejection in 8% of cases. And when they look at the post-transplant isocyanine titers at day 7, 14, 21, etc., there was no rebound. You see the dashed line is the rituximab patient, no rebound. Conversely, for those who have had no rituximab, there was a rebound, and this rebound explained the antibody-mediated rejections. So indeed, the isocyanine rebound is normal when you perform the plasmapheresis or the double filtration plasmapheresis sessions or specific immunoadsorption, because you have to retrieve from the interstitium all the IgG isoagglutinins. However, once you transplant the patient with a safe low levels of isoagglutinins, post-transplant, there is no rebound in most of the patients. And so therefore, we no longer monitor the isocyanine titers post-transplant because it's useless. And the magical point with ABO incompatibility is the accommodation process, which is an active process, which certainly involves complement pathway. And this results in the fact that after transplantation, there is no rebound of the isocyanine titers, and the kidney is not rejected thanks to having immunosuppression. There has been a study whereby the patient had no apheresis, just rituximab to start with, to see whether it was sufficient to decrease the isocyanine titers, to bring them down below 1 into 8. And you see, apart from 2 patients in whom it was possible, the others it was not possible. And so therefore, we need to have at the same time rituximab and apheresis. And finally, another study that was published recently from Japan, and they had 2 series of patients. One series of patients who have had 2 doses of rituximab, but without apheresis because the titers were lower than or equal to 1 into 64, and the target is 1 into 8, I recall you. And the control group was treated with apheresis plus rituximab. And guess what? Antibody-mediated rejections were observed within the first month post-transplant only in those who have had no apheresis. And the allograph losses due to thrombotic macroangiopathy in one case and antibody-mediated rejection in the other case were observed in those patients who have had no apheresis but just rituximab. So at the end of the day, because in this case, the patient still has IgM at the time of transplantation. In some cases, in some patients, this results in the poor outcome. So you understood that we need rituximab. This is the current protocol in my center, plus either plasmapheresis or double filtration plasmapheresis or immunoadsorption according to the titers. Plus, we start immunosuppression, as I said, as of day minus 15 pre-transplant, and we use antibiotic prophylaxis in order to avoid infectious complication. And the day pre-transplant, always perform a plasmapheresis session with fresh frozen plasma in order to replenish the clotting factors. Induction therapy is based on basiliximab in order not to be too immunosuppressive. The patients have already had rituximab. And post-transplant, we use the same immunosuppressive regime with tacrolimus, MMF, and steroids. And after 2 to 3 weeks, we replace MMF by everolimus. Why is that? Because the ABO incompatible transplants are much prone than the ABO compatible to develop a BKV reactivation, and BKV reactivation might be prevented to some extent by using everolimus instead of MMF. So I can claim that out of more than 50 ABOI cases in my center, we did not lose a single transplant within the first year post-transplant due to thrombotic microangiopathy. That is to say, it's very safe, provided that you take into account the IgM titers before transplant. So overall, the results of ABO incompatible transplant as compared to ABO compatible living donor kidney transplantations are the results of the European. And you see patient survival, graft survival, it's absolutely similar across the two groups. And this is true if the patient has had either plasma exchange or immunoadsorption, specific immunoadsorption to be desensitized. And there is also no difference with regards to the type of incompatibility, A incompatible or B incompatible. This is the data from Japan. These are the data from the UK. It's very interesting. Why is that? Because you see, when they look at the altruistic donor, this is a living donor, but altruistic one, or a pair exchange donor, or an ABO incompatible living kidney donor, the results are actually the same. So it means that when and where you cannot have access to pair donation exchange, you can rely on ABO incompatible kidney transplantation. So, meta-analyses are very popular when we want to address one question and we make a meta-analysis. And indeed, the meta-analyses are not the gold standard because they have major pitfalls. However, so this meta-analysis included 26 studies, totalizing more than 1,300 patients, ABO incompatible, that were compared to almost 5,000 ABO compatible control. And what they found was that with regards to patient survival, it was slightly worse for ABO incompatible. And this was true for when the desensitization was based on plasmapheresis or specific immunoadsorption, even though the difference is only 2% at 1 year regarding patient survival. And this was also true for 1 year uncensored graft survival. With regards to the complications the patients had, you see there were severe non-viral infection, and the risk ratio was increasing 44%. So regarding viral infection, CMV and BK virus was significantly increased, particularly for both of them. Biopsy acute rejection as well as antibody-mediated rejection were significantly more important, which makes sense. And finally, the bleeding complications around surgery were significantly increased in patients who were ABO incompatible kidney transplant. And this is because we remove the clotting factors pre-transplant, and see if we do not think to replenish the clotting factors at the time of transplant, this results in bleeding. The same for infectious complications. If we are very cautious with regards to preventing them, I can reassure you it's not increased in my experience. And finally, antibody-mediated rejection was significantly increased because of the isoagglutinin setting. However, a recent study from Switzerland has been published. It's a small series of patients, 45 ABO incompatible kidney transplant patients who were compared to ABO compatible living donor kidney transplants. And this was a 20-year study. And they found that patient graft survival, graft function were comparable between the two groups, which is very important. And also they found that there was no significant differences in terms of complications, readmission rates, length of readmission, as well as infectious complication and rejection rates. And there were only 4 kidney transplant centers And indeed, when you have a meta-analysis, you pull 26 studies, and so therefore uh, the management of patients is very heterogeneous, whereas here it's only 4 dedicated centers in Switzerland, and thanks to their management, the complications are very, very few. This is the graft survival. A recent study from Korea is very interesting. Why is that? Because they compared the outcome of 426 patients who have had ABO incompatible living kidney transplantation to patients who were on the kidney deceased donor waiting list with or without a deceased donor transplant during the observation period, okay, 10 years. And they look at the patient survival. And what they found was that the best patient survival was obtained in those who were right away transplanted with an ABO incompatible living donor, as compared to those who were waitlisted and who subsequently benefited from a kidney allograft. And finally,
Please,
those who were,
Dr. Rostin, please.
yeah,
I think we have a mismatch between the audio and the slides. Please,
oh, sorry.
Can you stop sharing and reshare your presentation, please?
Oh, I'm so sorry for that. And so can you see my screen or not?
Not yet.
Not yet. Oh, I'm so sad for that. So, afficher, partager, wait. Okay. Okay, I'm so sorry. So can you see my screen or not? Can you
Not
see
yet.
it?
Not yet.
And now? Can you see the screen?
Not yet.
No.
Oh, really?
It tells us that you're trying to share the
It's
screen. Now
okay. Now it's
now
okay.
we
Now it's
now we
okay?
see.
Yes, we see the 51 slides.
Okay, okay. So, so the post-transplant management, we do not monitor the azoxystrobin titers unless there is a suspicion of acute rejection. However, we have a close monitoring of diuresis and serum creatinine within the first days post-transplant, which is important because as long as we have a suspicion of azoxystrobin-mediated rejection, we do not perform kidney allograft biopsy, but right away we treat the patient. And so indeed, rejections might occur. Cellular rejection, it's not much more frequent as compared to ABO compatible transplantation. Conversely, the specificity resides in isoglin-mediated humoral rejection, and this occurs in 5 to 15% of cases, and it's always before day 21, that is to say, before accommodation takes place. And in some very rare patients, it occurs lately because they do not accommodate. And the symptoms are always the same: mild fever and sudden oligoanuria and rise in serum creatinine. And so we have to verify the arterial as well as the vein patency, as well as the ureter patency. And if it's patent, the kidney biopsy is not necessary because in all the cases, this will show acute tubular necrosis, interstitial hemorrhage, and diffuse C4D deposits. And if we make a kidney biopsy, this will delay the plasmapheresis, which is the required treatment. And so we have to urgently implement plasmapheresis 226, and we close the series by rituximab. And in most of the cases, the patient will recover. And if the event they do not recover, we can use eculizumab. It's very rare. So this is a typical case from my center in 2017. And so you see the titers in blue, dark blue for IgGs, and light blue from IgMs were low to start with. And the day of transplant, they are below 1:4. So the patient was transplanted. Post-transplant, the serum creatinine decreased for 2 days, but the next 2 days it increased, and the fifth day it became unusual. And so everything was patent. We performed 7 sessions of plasmapheresis plus daily steroid boluses, and he recovered diuresis, and he was infused with rituximab 7 days after starting the therapy. And now currently serum creatinine is 1.6, so he recovered. So this is a typical case of antibody-mediated rejection. And what are the post-transplant complications? As I said earlier, this is a study from the Netherlands. The most important one is the surgical one, is intraoperative blood loss. And you see the blood loss is twice as much for ABO incompatible as compared to ABO compatible living kidney transplant patients. And this is due to the fact that the clotting factors, as I said, were depleted pre-transplant and not replenished pre-transplant. This was a series of patients that we published some times ago, in which we look at the technical failures in ABOI or ABO compatible living kidney transplant patients. You see there were no differences regarding venous arterial complications, urine leakage, lymphocyte or peritoneal breach. And finally, very recently, to finish with, there was a French series of patients that were reported. 23 patients who had ABO incompatible transplant developed very early on. You see, median day, 1 day post-transplant, thrombotic microangiopathy. And most of them have had biological features of TMA. And those who have had a kidney biopsy, they all had features of active TMA. And so indeed, all the patients were treated as such with plasmapheresis plus eculizumab, but you see 1/3 of had lost their graft. And guess what? It's trivial. They found in the meta-analysis that the only predictive factors for having thrombotic microangiopathy was the titers of IgGs and IgM the day of transplantation. It's trivial because it should have never been happened. And so I am proud of the fact that I never experienced cases of thrombotic microangiopathy in my series of ABOI kidney transplantation because we pay a lot of attention to the isoclin titers before transplantation. This is precision medicine. So it's precision medicine, and if you are meticulous, you've got no graft failure because of the incompatibility. And the only patient in my series that has lost his kidney transplant, this was an acute antibody-mediated rejection which occurred after an episode of influenza infection. He had pneumonia, and it developed a few days later because of cross-reactivity, most likely, and antibody-mediated rejection, which was intractable. And finally, the most important infectious complication for me in my hand is BKV reactivation. As you know, in the setting of ABO compatible transplantation, the risk of having BKV reactivation ending up in BK nephropathy is less than 10%. Conversely, it's 2 times higher for those who have ABO incompatible kidney transplantation in this German series. And in the registry, in the US UNOS registry, you can see that the likelihood of developing BK virus nephropathy is far much higher in ABO incompatible transplant as compared to HLA incompatible transplant, in spite if they have had in both scenarios desensitization at pre-transplant. And currently, we still do not know why. And amongst the independent predictive factors for BK virus nephropathy in the American series, they found that the older the patient, the higher the risk, and indeed the ABO incompatibility. So to conclude, friends, ladies, gentlemen, ABO incompatible kidney transplantation results in the long term in comparable results to those obtained with ABO compatible kidney transplantation, and this is thanks to accommodation that can be bridged out as in one of patients by acute infection. It is possible to desensitize patients with very high insulin titers. I didn't show you the results, but in India, in my center, we are able to deal with these patients. Rituximab is mandatory pre-transplant in every case. Apheresis is also required pre-transplant, except in the cases where the titers are very, very low, below 1 into 8. Isoclin-mediated humor rejection occurs mostly in the very first weeks post-transplant, with or without isoclin titer rebound, and so therefore it's no need to monitor them. Desensitization protocols are easy to implement and are not too expensive. And I can quote my mentee in Pakistan, Dr. Navid Sarwar, with which we were able to develop a very successful ABOI kidney transplant program in Pakistan. And very soon in Morocco, we're going to set up the first patients with ABO incompatible transplantation. And finally, ABO incompatible kidney transplantation is thus a good alternative to ABO compatible setting when no compatible donor is available around. On that, I thank you for your attention. Hello?
Thank you very much, Professor Rostin. I ask Dr. May Hassaballah to introduce the second speaker, Dr. Zunaid Bardeh. Please,
Yes,
Dr.
it's
Hassaballah.
my pleasure to introduce Professor Zunaid Baradi. Is qualified at the University of Cape Town 1993, and he trained as physician, then as nephrologist at the Groote Schuur Hospital, Cape Town, where he continues to work. He runs his renal transplant clinic and is involved in all aspects of living kidney donations. His hospital does about 50 to 60 kidney transplants per year, including living and deceased donor transplants, as well as HIV positive to positive patients. And more recently, starting the first ABO compatible kidney transplant and kidney pair donation programs in South Africa. He is an exclusive committee member of the South African Transplantation Society, the South African Nephrology Society, South African Minister of Health Ministerial Advisory Committee on Organ Transplantations, and his research interests include desensitization and immunosuppressive protocols, as well as HIV positive to kidney positive transplants. He will be addressing the important subject of kidney pair donation. Please, Professor Zunaid.
Just Dr. Hassaballah, please, and Dr. Zunaid, I remind you that the discussion session will take place after both presentations. And I ask participants to post their questions in the chat through the session, and our moderator will address them during the discussion. So please, Dr. Zunaid, go ahead, please.
Okay, thank you, and good evening, everybody. Okay, so I'm very happy to present on this topic. This is just a picture of our hospital where we work, which is the Groote Schuur Hospital in Cape Town. I don't have any disclosures except to say that I'm quite a keen birder, and that's one of our local endemic birds in South Africa and in the Cape area. Also, my other disclosure is I don't have a huge experience with kidney pair donation. We're just starting our program here, but I can just outline the what we've come up with so far. So I'm going to just start, in fact, with a case report from our hospital, Groote Schuur GSH, stands for Groote Schuur. And we had recently a wife that wanted to donate a kidney to her husband, and he didn't have any other donor options. As you can see, they were ABO incompatible. The wife was blood group B, and husband was blood group A. Fortunately, they didn't have a very high IgM, isohemagglutinin titer of, it was only 1 in 4, but the other issue was that they had he had a very strong donor-specific antibody, this DQ antibody with an MFI of about 6,500. So it was both an ABO and HLA incompatible transplant. And then I also work at the neighboring UCT hospital, and I came across this a son who wanted to donate a kidney to his father, and as you can see, they were also ABO incompatible. He had a very high, well, relatively high anti-A titer of 256, the father. And obviously they were haploidentical, being a father, being a son to a father. So that got me thinking about kidney pair donation again. We had a three-way exchange about 6 years ago, and then our program, COVID came along, and our program it became non-functional. So just for both these patients, we could obviously do a desensitization and an ABA-incompatible transplant as outlined by Professor Rostang so elegantly in the last talk. So I'm not going to go into the details of this, but there are lots of ways to potentially have done this transplant, but it would have been a high risk, well, two high risk transplants, with all the concomitant risks that go with it. And he's talked about ABA incompatible transplants. Our program has been going for about 2.5 years now, and we've done about 15 transplants. And we only use the glycosorb immunoabsorption technique, but I'm not going to talk about that any further because that's been covered. So, like I said, the desensitization is clinically complex. There's financial barriers because of the cost of the immunosuppression, and especially plasma exchange and immunoabsorption is quite expensive, the columns. There's obviously increased risk of the complications like we've talked about, and there are obviously logistics involved in crossing these barriers, which can be challenging in countries where this doesn't exist. So there are alternative strategies. The one thing is to prioritize a patient which is sensitized on a deceased donor waiting list, but that doesn't really help you with, it can help you with also with ABA incompatibility. The next thing is kidney pair donation, which we're going to talk about. And then linked to that is domino donations and altruistic donations. So this is just a screenshot of our deceased donor waiting list, which we've got online in our region of the country. I'm not going to go into that, but that is your option. But if you don't have deceased donor transplantation, which doesn't exist in many countries in Africa in particular, or if you've got very long waiting lists, which is all over the world, and especially with COVID, our waiting list got even longer, then you have to look at other options. And that's where we get to kidney pair donation. I'm sure most people have heard about it, but just the concept is you've got a living donor who's healthy but is incompatible in some way, either ABO or HLA incompatible. And when you put multiple pairs like this into a program, you try to find a match where. And the simplest is a two-way match where the first donor will give to the second recipient and vice versa. You can make it can become more complicated when it's a three-way match or a four-way match. It just depends how big your donor recipient pool is. You do rely on a critical number of donors and recipient pairs in a pool to be able to start finding matches. It's probably somewhere in the order of at least 15 or 20, and obviously the more you have, the more likely you are to find a match. Looking at the history of kidney pair donation, it's not been around for that long. It was suggested back in 1986 by Rappaport, and then in the early 90s, it started taking off firstly in the Far East, and then it slowly spread its way across the world, and now it's become it's something that exists in most sort of countries with large transplant programs. And as more recently, this table just goes to 2010 when it was started in Australia and New Zealand. In what I call lower middle income countries, which most of Africa unfortunately falls under, you can see it's only in these Asian countries, and I don't think there's a program anywhere in Africa as far as I'm aware, except for, like I said, we're just about launching our first one in South Africa. To do kidney pair donation, it's quite complex. The algorithms, can be quite complicated. In fact, the person that developed it first was Dr. Alvin Roth, who was an economist, in fact, and he was actually awarded the Nobel Prize in 2012 for developing these algorithms. And this is just taken from his speech at the the Nobel ceremony where he was awarded the prize, and I mean, just he said something which probably sounds quite obvious: disease is more expensive than health. And just to also say that these algorithms were not only designed to find kidney pair donors, matching kidney pair donors, but also they matched students with universities and even doctors with hospitals. So you can use the same algorithm to find the best match between two things which might not initially be matched. Another concept which is quite important with kidney pair donation, or actually what we can call kidney exchange programs in general, is what's called a non-directed altruistic living donor, or NDAD for short. So it's normally a person who wishes to donate a kidney to a person with advanced kidney disease or needing a transplant who they don't know, or they might originally have known somebody, and wanted to donate to somebody, a family member or a friend, but were unable to do so because either a more suitable donor became available, or the intended recipient was unable to receive a transplant for some sort of other medical reason, or might have died in fact, or they were found to be tissue or blood group incompatible where there was no KPD program available. So in countries where this has really taken off, things like ABO incompatible transplants, or have actually become quite uncommon, because this is obviously a much better way to do it. Just to say, kidney change, or where do NDADs fit in this whole process? So instead of doing a two-way swap with donor one, maybe giving to recipient two and vice versa, here you've got donor one giving to recipient two, but donor two giving to recipient three. So forming a chain, or if you can imagine, a domino effect, and that can carry on almost indefinitely, but that would always leave recipient one out in the cold, except if you do have these non-directed altruistic donors NDAD. So, and one NDAD can set off a chain which can theoretically go on, for a very long time. I mean, I think there's examples in the States where there's a few hundred patients that have been transplanted because of one NDAD. How do we assess these donors and recipients? It's the standard way. I mean, there's no difference in the assessment, and I mean, I've just put the KDIGO guidelines, which most people would follow in terms of assessing donors and recipients. And so this is a summary from our program, what we need to enter a kidney pair donation program. So obviously you need an eligible recipient who has an incompatible, who is usually incompatible donor, although we'll come to how you might even use an incompatible, a compatible pair. So in South Africa, we've got this what's called the Ministerial Advisory Committee for Organ Transplantation, and they assess all unrelated transplants. So these are inevitably are going to be unrelated transplants. So although your original pair might be related, we've put that in our protocol that they need to be assessed and approved by this committee, so that when an unrelated match is found, that they've already been pre-approved. Because occasionally the committee might think that, might disagree to say that this donor is not an eligible donor, or the recipient. So they both should be ready, fairly ready for transplant surgery. There mustn't be some other issue that needs to be attended to. Ideally, they should be listed on a deceased donor waiting list, but this is not obviously essential. They must both be willing and consent to actually enter the KPD program, and both must have blood group typing and HLA typing for at least those four loci, and the results need to be then available for the KPD coordinator. We also want the recipient to have antibodies which are not old. I mean, so we want them fairly recent. They are expensive tests to do, but we want them, ideally within the last few months, and no older than 6 months old. And obviously, if there's any sensitizing event, that needs to be reported to the the KPD program coordinators. Then we'll do match runs, although as I said, we're quite early on, so we haven't actually done a match run on the KPD program. And if a pair is found, then you have to do an actual CDC cross match to confirm that this is truly a compatible transplant, because obviously the program finds it on a virtual cross match. And then we need to send a letter to this Ministerial Advisory Committee to approve the new pair, and then set the date and time, and place for when this transplant's going to occur. And it needs to be simultaneous. Most programs want it simultaneously. So we at the moment use this very basic Microsoft Access software, which we actually loaned to colleagues by colleagues in the States. It does work, but it doesn't have ongoing support. So there are many other options available. One of our moderators is actually the CEO of the Alliance for Paired Kidney Donation. So I'm sure he can maybe tell us more about that. And then another one which we came across recently is called KEPSOFT, Kidney Exchange Program Software Collaborative, and they're based out at the University of Glasgow. So that's an alternative option, and they're open to people contacting them as well. It's quite difficult to develop this kind of software on your own, as you can imagine. I mean, it's quite complex algorithms involved. So, but I suppose it is possible. And then if you look at some of the programs, they use additional ranking factors to help prioritize patients on a kidney exchange program. So one of the things you can do is look at the number of HLA mismatches, and if you find a better match, obviously, or then that might be a better pair to pick. The donor center and the recipient center distance between the two might be a factor. So you might want to keep it within one region or one province or even one city if that, obviously that's going to be more convenient. Other things to look at are the age differences between the two, the original donor, the incompatible donor, and the compatible one found by the program, or even donor and recipient age differences. Other factors are things like CMV and EBV mismatches, because that can cause problems further down the line. Time on dialysis, PRA, and then things like age or size mismatches. And I've just shown you, I've just listed the Mayo Clinic has these kind of factors where they found that when the age of the donor is less than age of the recipient is less than 50, you don't want the donor to be more than 10 years older, because that gives you worse outcomes. And then things like GFR mismatch when you're looking at the recipient's body surface area. So there was a study in 2015 published in NDT where they looked at some of these programs, which are national programs from countries with smaller populations, and I suppose the same would apply to countries with larger populations but with small transplant programs. And they looked at the Netherlands, UK, Canada, and Australia, and some of the differences between them. Interestingly, like the Netherlands only has one laboratory doing all of them, all the testing, whereas other countries have more than one laboratory. Some of them do multi-way and dominant, actually all of them do that. And interestingly, the UK and Australia allow for ABO incompatible transplants on the KPD program, because like we've heard, that the outcomes can be very good with kidney pair donation, with ABO incompatible transplants. And then they have a different amount of antigens which they test for. So other strategies to improve finding a match, the Dutch program found that the three-way exchange was actually the optimal for them. It increased the rates of people transplanted on the program from 54 to 66%. And that was the optimal length to achieve, the best matching and to allow simultaneous transplants to happen in a way that wasn't too logistically challenging. Like I said, including ABO and HLA compatible pairs actually is a useful way to increase the number of pairs in the program, and then allow more transplants to happen. And there could be benefits for those patients in finding a better match, or a better age match as well, besides for HLA matching, better age match and CMV matching. And then you can combine desensitization with KPD. So if you've got a very sensitized patient, you can put them on and maybe set very high targets for their donor-specific antibodies, which they might have, and then allow a transplant to occur that way with desensitization. I've said the Australian program allows for ABO incompatible transplants if the titer isn't too high, and then some programs allow using non-A1 donors, or as an O donor. I'd be interested to know what Professor Rostang, I mean, how he, how they deal with non-A1 donors in their ABO incompatible program. And then, like I've said, using non-directed altruistic donors to start a chain. And then you can customize what's called an unacceptable antigen for a recipient, which means they've got a very high donor-specific antibody. You can customize that. Instead of using one cutoff MFI, like say 2000 maybe, you can make it higher for an HLA-C or maybe lower for certain other antigens. Another interesting aspect which there is an uniformity on is anonymity. So anonymous allocation is sort of the norm in most sort of Western European countries, but it's not the norm in Asian countries and in Romania. And in areas where anonymity is not maintained, the intended donor and recipient actually are sort of they must actually meet and almost get to know each other and exchange information. And in India, I mean that is standard practice, and also the goal is to increase trust and transparency between the transplant team and the people administering the program. And there was even a study done on this, published in Transplant International in 2023, where they looked at this question of anonymity and the legal issues around it. They reviewed 50 papers and they came up with 62 reasons that might have been discussed, and they divided them up into these 13 categories. And there was things for and against anonymity, including protection against harm. It's in some places it's quite unrealistic to implement, and there were lots of other factors they looked at. But the conclusion was that there's no reason legally to actually force anonymity, and it sort of needs to be individualized, and then it needs to be careful counseling and follow up. The other issue is reimbursement. So many countries do allow for reimbursement for living donors in general, and especially these patients on kidney pair donation for things like lost wages, travel cost, accommodation, and childcare, but other countries don't. And that's up to the individual programs and the country to look at. Yeah, another one of our attendees, our moderators, Professor Rees, is part of this Global Kidney Exchange. I think he's he published on it, and I think that's part of the APKD program. So it's an international program that facilitates cross-border exchanges. And the idea was to, between immunologically incompatible donor-recipient pairs in the high-income countries and maybe even compatible pairs in low-income countries, to assist with those highly sensitized patients and overcome those immunological barriers. And then there'd be I think there's, the way I understand it, the patients coming or their medical insurance from high income countries would actually pay for the transplants in the lower income countries. And it has the potential to expand the genetic diversity of the donor pool and would help transplants in highly immunized patients in those high income countries. There's been some criticism about this. I mean, it's not uniformly accepted that it's a good thing to do. But some people have said, if it's not properly monitored, there could be issues around, potentially, it's payment for organs and that sort of thing. So other people have looked at alternatives, and basically the alternative is to look at kidney pair donation programs within countries in the same area or that have similar economical and societal development countries. They should have similar ethical and cultural values, and there should be a robust and sustainable framework with legal certainty between donors and patients and professionals in place. And there should be basically comparable conditions and access to all the patients across groups. So it is doable maybe amongst countries, but they need to be similar in their background and legal and framework and socioeconomically, like countries within the European Union would be an example, or maybe I mean, if I'm just throwing it off the top of my head, like say the North African countries, maybe that could be something where if there's similarity between those countries. So these are some of the proposals that they came up with to implement KPD in developing countries, is to limit the length of the exchange to 3-way exchanges, similar to what they found in that Dutch in the Dutch KPD program, to include these non-directed donors, NDADs, to include compatible pairs, to consider avoidance of anonymity because of the technical challenges, especially if you're having two transplants, two paired exchange in the same hospital, that would be quite tricky to manage at times. To employ software instead of a manual way to find a match, sort of we find our patients in a manual way. Always to try to do this surgery simultaneously at the start, if at all possible, so that one donor doesn't pull out or after the other one's donated. And you have to have robust protocols to protect the recipients if that does happen, so that they can get a kidney prioritized on a deceased donor waiting list, or if the one transplant somehow fails, or there was damage to the kidney, or loss of a kidney. And then to rather ship the organ than let the donor travel, and have robust surveillance strategies in place so that there's no organ trafficking. And once established, some countries have a voucher system, which it's quite complicated, and I don't think we can go into that now. So just to get back to our patient, I told you about those two pairs. When we look, I mean, that was quite an easy one to find. It was A to a B and a B to a A. So when they swapped, when we did the kidney pair donation, we had two blood group compatible transplants, and now this patient that initially had that strong donor specific antibody had no donor specific antibody. So we had an ABO and HLA compatible transplant. That was the recipient at our hospital, and then at the neighboring hospital, that patient that had the very high titer anti-A titers got a compatible transplant, and pretty amazingly, his new donor was also haploidentical, so he really scored here. I mean, I don't know how that happened. I mean, they're not related at all, but they were basically haploidentical as well. So we did that transplant exactly 1 month ago, and both donors and recipients are doing well. I've also, we had to work out how we're going to tackle, these ABO incompatible patients, and how we're going to link them to our kidney pair donations. So I've come up with this algorithm. It's quite complicated, but basically, if you do have a patient with an ABO or HLA incompatible living donor, firstly, obviously look for an alternative donor and work up that donor. If they are compatible, then do the transplant. But if they're not compatible, if they're ABO incompatible and not HLA incompatible, then consider doing an ABO incompatible transplant. If they if they don't have a ABO or HLA incompatible transplant, and they agreed to go on to the kidney pair donation program, or there was never an alternative donor, then you enter them on your KPD program. And basically, if they don't find a match, then you can, and they don't have a positive CDC cross match, you can go ahead and do quite a high risk, HLA or ABO incompatible transplant. But if they don't meet that, they'll have to wait on the deceased donor waiting list. Or if they don't want to stay on the program, they can wait on the deceased donor waiting list. But if they do want to wait longer, you can keep them on this program. So it's just one way of looking at all the options that are available to patients who have an incompatible living donor. The Mayo Clinic looked at some other factors, and I've mentioned these. Basically, if they're ABO HLA incompatible, you put them in the KPD program. But if they're compatible, but they've got one of these mismatches for CMV, EBV, age, or size, basically they should go onto this KPD program unless they opt out. But even if they don't have any of those, if they opt in, they can still go onto the KPD program. So they're pushing more and more patients towards KPD because of these reasons, really, because there are lots of benefits of KPD or kidney exchange programs. You get a better immunological age or size match. So you end up with a safer transplant which lasts longer and is cheaper to perform. You can do more kidney transplants. I mean, kidney transplants is the best option in terms of renal replacement, and it obviously does promote cooperation between transplant centers, within your region, within your country, or maybe across countries, if that's the way that your program is set up. Yeah, that's the end of my talk. Thank you.
Thank you very much, Professor Zenaid. Very informative talk. Thank you very much. I think it's time for questions and answers discussion.
I see that Professor Abdounyang, the president of AFRAN, is with us. So it's a great pleasure for us. Dr. Hasaballah and Dr. Rees, please, you can open the discussion with the
Thank you.
message from the chat.
Thank you very much. So, Dr. Rostang, I really appreciate your wonderful talk. I have a couple questions. The first is, I noticed when you were giving the talk and you showed the data from 2000 until 2012 in Japan, they had 81% tenure graft survival. And I just wonder if you would talk about whether you think it's possible that accommodation might play a role in being giving other forms of rejection and not just.
Okay, so if I understood correctly, the question is to know whether there is a breach in accommodation in the long run, which might explain why some kidneys are lost. Indeed, it's possible. However, we still do not know yet what is the background for accommodation and why it's breached in some patients. And so at the end of the day, there is no study so far that examine the real causes of allograft losses after ABO incompatible kidney transplantation. I mean, histological causes with serial kidney biopsies.
Dr. Bardet, are
Sorry, I missed that. Was it a question for me?
Doris, I think you have a problem with your connection. If you can repeat, please, the question.
Can you hear me now?
Yes.
Wonderful. Sorry about that. Dr. Bardet, our other speaker, asked Dr. Rostang, how do you approach non-A1 ABO incompatible transplantation?
Dr. Bardet and Dr. Rostan, please.
Well, on my side, I didn't hear Michael Rees, and so therefore I don't know what was the last part of the question.
Let me try again. Can you hear me now, Dr. Rostang?
It's better. It's better.
Oh, okay. Dr. Bardet actually is the one asking this question, the other speaker, and he asks you, how do you approach non-A1 or A2, for example, ABO incompatible transplantation?
Okay, this is a good point. Indeed, we know that the density on endothelial cells of A2 antigen is far much lower than that of A1. There is a difference of at least 1 log, which is huge. So it means that there are in the States, but also in France, a program for A2 into B recipients having very low titers of anti-A. So it means that it's doable because A2 is very lightly antigenic. However, I came across with one patient who did not accommodate at all. It was A2 into O, and he presented with 2 episodes of acute rejection. Well, this was resolved and now he's fine. But so, indeed, yes, A2 into something B, it's doable provided the titers of anti-A are very low. Yes. And so this should be considered as ABO compatible.
Can I have a follow-up question on that? I mean, what do you consider a low titer for that, for the A2 or non-A1? And would you use rituximab for a transplant like that or not?
Okay, so if it's a deceased donor, because we're talking about the US program, I don't know if it's still existing or not. But in France, there is an A2 into B program for deceased donors. And I'm talking about that. And so the recipient has to have titers below 1 into 4 because it's deceased donation. So therefore, there is no manipulation pre-transplant. And so in this situation, the patient is induced with ATG and rituximab, single shot is given post-transplant. And so far, we have had a patient recently that was transplanted thanks to this program. Everything went smoothly, so it's doable. And if it's kidney pair donation, well, in this case, you have time to make one rituximab infusion, 1 month transplant, and so I think A2 into B or into O, it's doable, provided the titers are below 1 into 4.
And for living donor transplants, what would you do different?
I would use the same cutoff because yeah, because we don't have enough data, and there was a study that was a protocol, not a study, a protocol that was started in Australia and it was abandoned very rapidly, whereby it was A2 into B without any desensitization. The titers were higher than 1 into 4 to 1 into 16 or 32, I forgot, and they ended up with 3 allograft losses the day of transplant. So it's risky. Even though in some patients it goes well, in others it's a disaster. So we have to keep in mind that it's incompatibility, and yeah. And
Thank you.
there was some professor in TSAR posted a question with regards to the long-term results of ABO incompatible kidney transplantation within the registries. And to my knowledge, there are very few registries. The first one is the study I shared with you from the UK. It's a very nice registry data study. In the US, I think there are no recent data within the last 8 years with regards to ABO incompatible kidney transplantation. And there are the CTA data from Europe, but they have not been updated recently. And finally, in Japan, they have long-term good data, I think, yeah.
Professor Rothstein, you mentioned that you don't need to do a biopsy for ejections in ABO incompatible, considering that then probably we have TMA. So would you like to elaborate on that? And in your cohort, how
Yeah.
many of those patients that you didn't do a biopsy?
I think this point is very important. Indeed, thank you for pointing that out. So I used to make a kidney biopsy when I had a suspicion of acute rejection. So because I started in 2011 and in one former hospital, and then I kept on since 2016 in Ronald. And so altogether, I manage more than 150 ABOI kidney transplantations. And so at the very beginning, we are performing a kidney biopsy, which was showing either acute tubular necrosis, if it was an early biopsy, or it was showing interstitial hemorrhage, or only once in my life, some features in some glomeruli of TMA, but with no systemic TMA, as I said. And so the treatment is always the same. The treatment relies on plasmapheresis that removes complement factors, most likely, which what eculizumab is able to do, but eculizumab is so expensive. And so if you make a biopsy, you will delay your plasmapheresis to the next day because of bleeding issues. And so in my hands, it's not valuable. And you know, this very sad series of France, whereby they have had 23 cases of TMA, which is a disaster. Most of the patients have had 17 out of 23 have had a kidney biopsy, and therefore the treatment was slightly delayed by 1 day for plasmapheresis. And this might explain why 1/3 of them lost their kidneys. So for me, it's a clinical diagnosis.
So I have also a
It's based
question
on my
from,
experience of 150 patients, I think. And so based on that, I think it's
yeah,
it's
it
not an
doesn't add much.
obligation.
Yeah, yeah. Thank you. So we have this question from Professor Gamal Sadi about the use of obinutuzumab instead of rituximab.
Yes.
Have you had experience with that?
I saw his question. Indeed, obinutuzumab is far much efficient at depleting the B cells as compared to rituximab, and in addition to that, it does not interfere with the cross-match. However, for example, in France, obinutuzumab is only registered for lymphoma patients, so we cannot use it. So I think, and there are no series of patients who have been desensitized with obinutuzumab. So yes, you can use obinutuzumab, but it's not mandatory. Rituximab does the job very nicely.
And how about the combination of ATG with CD20, anti-CD20?
So I think ATG might be used for sure. And why didn't I use it for this series of 150 patients? Because indeed, this augment dramatically the burden of immunosuppression. You deplete the B cells, you deplete the T cells, and you may face with infectious complications. And if I'm proud of having very, very, very few infectious complications, it's thanks to prophylaxis, but also to not using, I think, ATG. And indeed, what we have to target for ABOI kidney transplantation is the B cells and not really the T cells, because the T cells are targeted by tacrolimus that is started pre-transplant. And so therefore, I think this might be helpful, but this might be associated with huge infectious complications. And so therefore, I do not recommend this combination, particularly in emerging countries where infectious complications are a big issue.
Right. Thank you.
Thank you, Dr. Rothstein. Dr. We have two questions for you. One from Todd.
Oh, there is a question.
Adia
Is it
asks,
safe to withdraw steroids in AB or incompatible transplantations? We have to be very cautious. And there was a series of patients reported from the team of Barcelona that has shown that those in whom steroids were withdrawn, some of them will develop creeping creatinine with subclinical rejection. And in my experience, we withdraw steroids after the first year in very stable patients, but in spite of that, one patient has presented, when we withdrew the steroids, acute T cell rejection, which was easily treated. So we have to be cautious, yes.
And about the vaccination?
Vaccination, indeed, all the patients, I didn't mention that, sorry. They are all vaccinated against pneumococcal infection, against meningococcal infection, diphtheria, tetanus, poliomyelitis, HBV, indeed, because if a patient is antigen HBs positive, we have to be very, very cautious. Indeed, it's not a good candidate for having a desensitization plus rituximab, but it's doable. Yeah, these are from vaccinations.
Okay.
thank you, Dr. Rothstein. Can you hear me?
Yes.
Yeah.
There's two questions for Dr. Bardet from Dr. Hakshi Does the software application automatically eliminate couples with CMV and EBV mismatch, or is there just a warning? Can you still hear me?
Yeah, I can hear you. Look, it really
Okay,
depends on
and
which
the, and
program.
this,
Can I carry on?
and the
Yeah.
second question is, what safeguards exist to ensure equity and transparency in donor-recipient matching in the KPD program?
Okay, well, I think the first one is, look, I don't have a lot of experience with this, but it's whatever you put into the program, right? So if you put EBV and CMV status and you make that one of your search criteria, then it will look at that. But if you take that out, it won't look at it. So it's really, these programs can be quite flexible. It's really up to you to decide what is important. I mean, you can leave it as just um, a blood group, matching and look at unacceptable antigens and just look at it purely immunologically, or you can add other variables in as you like, and it can get more complicated that way. And it all depends on what search factors you put into it. Um, and the other one was about the safeguards on transparency. Well, I mean, the whole point is if you have a program, it needs to be accessible and discussed with all the users of the program, being all the transplant teams that are forwarding their patients to the program, and there needs to be an independent authority, probably set up by the government to oversee the program, and I think that would ensure equity and transparency.
And so in South Africa, how many kidney pair exchange have you run so far and with ultimate kidney transplantation?
And we're really in the early days of our program.
Okay.
We've just done, at our center, we've done a three-way match a few years ago and this two-way match, but we in the process of setting up a national program at the moment. So it's very early days, yeah.
It's a good start. Congratulations. That's good.
Thank you.
Dr. Gordana asks if it's possible for other countries from the SC region to join with them in South Africa.
Well, like I said in my talk, it is possible for countries in the same region that have a similar, socioeconomic and backgrounds and a similar sort of legal frameworks to join together, especially if the individual countries have very low volume. So that is theoretically possible. And I gave the examples of maybe the countries in North Africa, the Maghreb, maybe that have similar kind of sort of backgrounds to maybe to look at that. And in Southern Africa, we have what we call the SADC region. So it would be possible. I mean, obviously, if once you're crossing borders, it does get more complicated from a sort of a governmental and legal point of view. But it is theoretically possible. I mean, they've done that in the European Union, but I think that's a much more already integrated area.
Dr. David Thompson asks Dr. Rostang, do you find that the glycorex columns also impact clotting in some patients?
What is the question regarding glycorex?
Do you find that sometimes when you use the glycorex column, it also impacts the clotting?
Oh, yeah, okay. So it's a good question. Yes, no, it does not. So we made a study, limited study with a limited number of patients, and we assessed that, and there was no effect upon the clotting factors, and we published the data. This was in thrombosis, I think, and we compared plasmapheresis, DFPP, and immunoadsorption, and there was almost no effect on clotting factors. Yes, no.
Other questions?
There's another question from Dr. Mohammed Qasim. Can we do transplant in the case of positive HLA cross-matching? And so that's getting into a whole nother can of worms from ABO incompatible to HLA incompatible. I think that's the question.
In this case, the best thing to do is to have a kidney pair exchange program for sure, if it's doable. Conversely, where in France, it's complicated to have a kidney pair exchange program. It was very limited. Now it's slightly more open. And so therefore, we do on a yearly basis about 2 ABO-I HLA incompatible kidney transplantation. And recently, we did a pair. The cross match was indeed positive, and so the recipient was desensitized, and at the end of the day, everything was fine. Yes, yeah. So it's doable, but it's very tricky and challenging. So it's better to avoid it.
Dr. Bardet, Dr. Habchi asks, is it good or bad to cross-link patients genetically different around the world?
Well, I mean, I think there's two sides to that question. I mean, it's obviously you're not going to probably get as good a match if your populations are different, so you're going to get a higher HLA mismatch, but you might be less likely to get to have what's called an unacceptable antigen on a kidney exchange program because the antigens are so different. I don't know if you understand what the difference between that, but yeah, it's got its pros and cons. You're less likely to find a good match or a low HLA mismatch, but you're also less likely to get donor-specific antibodies for the same reason. And if you rely on your immunosuppression to stop rejection in a patient, that's not a good match, but with no DSAs, then it can be a good thing in a highly sensitized patient.
Another question, what are the long-term outcomes, patients and graft survival of ABO transplantation compared to ABO incompatible compared to ABO compatible in large registries?
So, thank you for the question, Professor Mariam. So the only registry data that we have so far recently are from the UK, as I said, and so pair exchange recipients as compared to altruistic donation, as compared to ABOI, resulted in the same patient and graft survival at 4 or 5 years, I think. So it's not long term, but at least it's reassuring. And in France, the data have not been published so far, but the results are very similar. So it's reassuring, but long-term data we don't have many, no.
Mm-hmm. And I think we have a question about monitoring of isoglobulins is not recommended in post-transplantation.
Monitoring the
monitoring of isoglobulins is not recommended,
no,
considering that we are anticipating rejection. So
I think it's not recommended because it's time consuming, it's tedious, and it's not valuable. Why is that? Because you may have acute antibody-mediated rejection without any rebound. And so therefore it's misleading. Conversely, I came across with a few cases when we reported on it with an increase in isoglin titers without any change in serum creatinine, and we made a biopsy. There was nothing special. I think within the first month post-transplant, not later on. And so therefore, at the very beginning, we were monitoring them on a daily basis for 2 weeks, and thereafter once a week, and now no longer.
yeah.
I'll do my best to translate this question from French. It's from Dr. Guiba from Mali, and he asks you, Dr.
Oh, is it possible for other countries than from South Africa region to participate to your kidney pair exchange program?
I think I've answered that. I mean, at the moment, we haven't really even got our program off the ground. So, we want to first get it going nationally before, we extend it to other countries. But it's possible for those other countries to directly, approach, the kidney exchange program, the two that I mentioned directly, and see if they want to set up their own programs. But it does make sense to have a larger donor recipient pool. So I think in the long term, it would make sense to have that, but it's got lots more logistical problems, once you go beyond your own country's borders.
But the prerequisite, I guess, is that the country in which the pair is has a law that permits kidney pair donation, no?
Sorry, I missed the second part of that.
I assume that it's only possible if the kidney pair exchange program is contracted with a country in which, by law, it's doable, it's legal. If it's not yet implemented, I think it's not possible, no?
Yeah, I agree. It needs to be. I mean, there are obviously legal challenges, and there have to be agreements between governments and that sort of thing. So,
Yeah.
it's
Because in the
much
case
more.
of Mali, so that this should be sorted out. Yeah. Okay.
Other questions?
Okay.
I have one question. Can you hear me, Dr. Rostang?
Yeah.
So I wonder if you could ex explain to me, when we do cross matches, we get rid of the IgM and just worry about IgG for HLA. Why is it that we don't have to worry about IgM, but in ABO incompatible transplantation, you have to worry about IgM?
Well, most likely because the complement activation through IgM, we know that it's much more efficient as compared to through IgGs first. Secondly, because anti-HLA IgMs most often are very transient and they do not result in acute or hyperacute rejection. We do not know why yet. And finally, why isoglutines IgG are not that bad, because most of them, it has been studied, I didn't show the data, most of them are IgG 2 or 4, mostly IgG 2, and so therefore they barely fix the complement, whereas IgG 1 and 3, they do so. And in the setting of HLA inactivity, most of the IgGs are Ig1 and 3. And this might explain why the cross match is positive. And so for reasons that we have not elucidated yet, these subtypes of IgGs, isoglutinine IgG2 or 4, anti-HLA antibodies IgG1 or 3, and the IgMs, most likely because there are much more IgMs, isokinins, as compared to IgM anti-HLA. This is my guess.
Thank you. And I'd ask this question, imagining the future.
Yeah.
Could you dream about what you've learned in both ABO and HLA incompatible transplantation to imagine how it might impact xenotransplantation, assuming that that is in our near future?
Yeah. So with regards to xenotransplantation, I think the way the pigs are edited so far, a lot of genes have been edited, including all the genes who are implicated in the complement cascade, and so therefore the xeno antigens are no longer a problem for the immediate hours or days post-transplant. And secondly, with regards to blocking CD40 ligand pathway with all the recent patients who have had a pig xenotransplant, a kidney pig xenotransplant, have had this blockade of CD40 ligand pathway, plus in addition rituximab plus ATG plus the rest, and this makes a difference most likely. So because the other thing I did not discuss is the thing that we can modify by perfusing ex vivo a human kidney to delete or to erase the A antigen or the B antigen on the endothelial surface, but it's transient, and so therefore this will come back later. So even though we manipulate the human kidney by perfusing with a solution that erases all the A or B, you still need to have a pre-treatment before transplantation in order to prevent the rebound, because it's just transient. But these are the future trends, yes.
Thank you very much. I think if
It's
there
my
are no
pleasure.
more questions, I think it's time to conclude our webinar. So, dear colleagues, ladies and gentlemen, as we come to the end of this enriching session, I would like to thank you all once again on behalf of the AFRAN Transplant Committee for your participation and engagement. A very special thanks to our distinguished speakers, Dr. Lionel Rostin from France, now in Thailand, I think, and Dr.
Yeah.
Zunaid Bardey from South Africa for their insightful and forward-thinking presentations. You have both shared with us case strategies and experiences that are crucial in addressing the global challenge of organ shortage. We are also deeply grateful to our excellent moderators, Dr. May Hasaballah from Egypt and Dr. Michael Rees from the USA, for guiding the discussion with clarity and expertise. Unfortunately, Dr. Ahmed Halawa from UK have another commitment with deceased donor kidney transplantation ongoing now. Our sincere appreciation goes once again also to Dr. Mariam Khadar from Tunisia and Dr. Gamal Saadi from Egypt, whose dedication and coordination made today's event possible. This sixth webinar is in our AFRAN Transplant webinar series, reinforces our collective commitment to advancing transplantation across the continent through shared knowledge and international cooperation. We look forward to seeing you again for our seventh webinar, scheduled for Friday, September 19th, 2025, which will focus on kidney transplantation in Eastern Africa, current situation and challenges. Until then, thank you all and goodbye.
Thank
Thank
you.
you. Have a nice evening.
Very much.
Bye-bye.
Thank
All of
you.
you. Bye-bye.
Bye.